today's webinar.
So hello everyone, and thank you, Kia Beth, for having me to present at this webinar. I hope everybody can hear me clearly. So today I'd like to discuss with you about the importance of following forensic principles in newborn drugs testing. So the objectives that we'll cover today is a background of the federal and state child welfare policies, which will lead us to the principles of forensic toxicology. Since the interpretation of the results is also key to approach the forensic cases, I will also cover some major factors that affect the test results to be considered. So the maternal drug use has negative impact on the child development through various pathways at the prenatal stage, as you can see. And it's not just that the drugs are toxic, but also the factors surrounding maternal drug use that lead to limited prenatal care. And those are social, economical, and psychological. This influence continues on after even the baby is born, since the drug use behavior may be associated with poor caregiving environment. And so at any point of time when the interventions are introduced, there are opportunities given to the babies to be protected and the families' lives to be changed. I'm sorry, there seem to have some difficulty. All right, can everybody see the slides that I just went through? Okay, I apologize for technical difficulty, but this chart is pretty much demonstrate what I just talked about. Now, talking about life-changing, the lawmakers propose some legal actions to make those changes and address the women using the drugs during pregnancy. They may be good or bad resolutions in a sense. It's a wide spectrum of solutions. It ranges from increasing the services to treat the pregnant women and children to criminalizing the mothers. And so in 2003, Keeping Children and Families Safe Act added this new eligibility requirement to get access to the child welfare funding under Child Abuse Prevention and Treatment Act. So this eligibility is that every state, or not every, a state must have a policy in place that the healthcare providers to notify the Child Protective Services when they recognize babies born with the symptoms resulted from prenatal drug exposure. However, not all the states are doing this. The notification to the CPS is only mandatory in some states. On top of that, in some states, prenatal drug exposure is considered as child abuse and neglect. So here I show you the map which states have such reporting laws. As of June 2015, there are 15 states require reporting when the abuse suspected, including Illinois state. 3 of them also require testing, and Kentucky requires the testing, but not so for the reporting. Substance abuse during pregnancy is considered in some states, actually one state, as criminal act. In 18 states, consider it as child abuse, and 3 states consider it as grounds for civil commitment. And states may arrange some different approaches to treat those pregnant women, besides of having the targeted program being created. and the pregnant women giving the priority access to general programs, or pregnant women being protected from discrimination in publicly funded programs. So as you can imagine, under such a legal system, drug tests can play a key role for the authorities to decide the best arrangement available, made for both the mothers and the babies. So keep that in mind. The drug test results must be presented as a valid and defensible evidence in court, and that is exactly the essence of forensic toxicology. So I'll cover the basic principles of forensic toxicology and what makes it defensible. So the first one is chain of custody. It's the type of document to record the whereabouts of the specimens all the way from the collection to through the testing to disposal. So on the screen you see this is the chain of custody or chain and control form for the forensic newborn drug testing used in our lab. There are some occasions that we need several attempts for meconium samples to be collected, and each attempt is recorded by who and when each collection attempts. At the end, the last collector sign there and seal the container with this strip of sticker, seal it across the container and send it to the lab. And when our lab receives a sample, we will check for the temperament of the sticker. If it's broken, we will reject it for testing because the chain of custody is broken. But if it's not, then the accessioner would receive the sample and sign it underneath of this requisition form. And as a specimen travels through the lab, each step of the way, the technicians would date, print, and sign at which purpose of the procedure that the sample is handled. So the next principle is regarding testing. At least two stages of testing must be done. So at first it's initial or so-called screening, testing for the presence or absence of a group of drugs. It is a non-specific term. It's generally done by immunoassays, and if the kits are not available, the instrumental screening techniques can be set up. And blind QC is quite an important concept under this stage of the testing. What it is the type of quality control that we know what the test results are behind the scene, but it is blinded from the analysts or technicians who are handling the batch until the data reviewer receives the data to review it. So in a sense that this blind QC is mingled with other specimens, and we don't know exactly what it is. And when we review the data, we would look for that particular sample matching up the expected test results. So if that test results appear to the different sample ID, we would know that there is some sample switching happening during the process, and the whole batch needs to be redone again with a separate aliquot of the samples. This is the whole redo process. So if this batch is valid, the samples that are negative for drugs will be released for the negative samples. For the samples that are tested presumptive positive in our toxicology lab term, the samples will be referred to confirmatory testing. There are two purposes of doing this. One is to confirm that what we screen positive is actually positive, and two, we report what it is actually positive for. We report it with identity and quantity of a specific drug. So it is, again, done by a separate aliquot from the initial testing that we did. It's tested with a different scientific principle than the initial testing. Majority of them are set up with chromatography separation / mass spectrometry detection. And at the end, there is this data certification stage before the samples results are released. At this stage, the data reviewer needs to see if the quality control meet the acceptance criteria, and it involves at least 2 people to review the data. And also the confirmatory results are reviewed along with the initial testing results. So keeping the principles I just introduced you, I also want to remind you that I have mentioned earlier that interpretation of the test results is key to approach the forensic cases. And when we approach the case, we need to have a full picture of the case history, what exactly happened, other than we receive the test samples to analyze it. And so the test results can only fit in this full picture to see if all those can explain the test results. So at the lab, there are also several factors we need to consider. And the huge pre-analytical factor is specimen type. These are the 4 specimen types that have been known for testing babies toxicology for a while, and they are different in various ways. The first aspect that they are different is detection window. So urine has the shortest detection window. We can only test for drugs within days of exposure. That makes a big difference compared to the hair, meconium, and umbilical cord specimens that have a much longer detection window. And what they do is that they collect the drugs and metabolites within this time frame to have this to test. And so the concentrations can't really correlate with any of the drug-taking event of the mothers, because we cannot tell when the mother last took the drug. We don't know how frequent the mother took the drug. We don't know how much of the drug dose this mom did at each time. And we don't know when the earliest the mom started taking drug. So we need to keep this in mind, that this is a reservoir type of specimens. In terms of sample collection, most of the urine, hair, and meconium types may not be sufficient following the forensic toxicology principle, especially for the samples that are positive for multiple drug classes that we need separate aliquot for each to confirm. And in that sense, umbilical cord is very favorable specimen type, because we hardly run into any problem running out of the sample to complete the casework. In terms of availability, there is not much data published out there how difficult it is to get access to urine and hair samples from the baby. But we have seen a study that only 80% of the babies can provide the meconium samples to be collected. And this is especially true when we approach the premature babies. It's very difficult to collect samples from those. So in that sense, every baby has an umbilical cord. In terms of timing, besides of the detection window, that we need to collect the urine within 3 days. The timing may be sensitive for umbilical cord, for meconium, I'm sorry, because after 2 days, we may start collecting meconium that is formed after baby was born. So there is some case that the babies show some neonatal abstinence symptoms, and the babies are given some drugs to treat the symptoms, and it turns out that drug shows up in the meconium testing results. So this history needs to be considered when we look at the positive results. For hair testing, in theory, it's not as time sensitive to collect it, although the more time we wait, the more environmental exposure factor would need to be considered when we're interpreting the data. For umbilical cord, though, since it's so easy to collect at birth, the timing is usually not a big issue for folks. Last but not least is the chain of custody integrity. In a few slides prior, I have shown you some boxes for the collectors to fill out each attempt. The collector gets the meconium samples before it's completed. And in that sense, it is a very high risk of breaking the chain of custody. And we did some internal survey of the chain of custody forms. We found that about 40% of the meconium samples that we received had more than 2 collection attempts. The last factors we need to consider, and this is also approach for professionals to evaluate the test methods to choose for the neonatal drug testing. So for urine, we need to be careful if you're asking your clinical laboratory if they can perform the urine drug testing. Make sure that their cutoff is not set up too high, because commonly the immunoassays we're using may be set like a standardized SAMHSA cutoff to be tested. And that may be too high for the neonatal drug exposure cases, and that needs to be considered. For hair, it usually involves the overnight process, so turnaround time is a consideration when we do choose the hair as a specimen type to approach the cases. For meconium, we need to look for the confirmatory methods that have the newborn-specific metabolites. For example, male hydroxybenzoylecgonine is the baby-specific metabolite for cocaine. So without those, we have some risk of having the false negative cases. Lastly, for umbilical cord, we do need some high sensitivity techniques, which I will show you in the next few slides to address that. So in the last few slides, I have 2 points to make here. Number one, if all 4 specimen types are collected from the same baby for the toxicology study, the test results don't need to be measured with each other. So that means one test does not dispute the other. In other words, the negative test results from urine specimen doesn't mean the positive results in umbilical cord is a false positive result. Or positive meconium results doesn't mean that the negative results from umbilical cord is wrong. So keeping the analytical factors in mind, and if you're evaluating some test results, I do have some data to show you based on the survey we did in the 6-month period of time from July to December 2014. So I will show you the survey by only the 13 classes of controlled substances that we're good at. So this is the test menu from 5 to 13 panel, and the colored dots show us which drug classes we test in each panel. And this is the number of samples we have collected in the 6-month period of time. I do want to say the limitation of this survey is that we don't know if the meconium and umbilical cord samples are matched when we do the survey. Very unlikely they're coming in the matching sample. However, we do think that this number is so big that we thought that the survey results is well represented. So here I display the test methods following the forensic toxicology principles for meconium versus umbilical cord test methods. A little bit of our history. We set up meconium test methods much earlier than that for umbilical cord test. And for that reason, we actually set up the umbilical cord test methods by looking for the cutoffs such a way that the positivity rates are comparable with one and the other. So you see that the screening methods are different between the two specimen types, and the way we confirm them are also quite different. So here's the results. The drug classes listed here are ranked by the positive rate we see in umbilical cord. The THC is the highest to the least PCP and piroxazine. And the positivity rates are shown here, and the umbilical cord's results are on the right-hand side. And for the same classes of drug, the positivity rate for meconium are on the left-hand side. So overall, in the whole picture, maybe there are some drug classes that don't have very well matched positivity rates, but their overall prevalences are very similar. Also, I want to point out that the highest ranking drug types are not only from the 5-panel, but also in the more extended panels of drugs. So let's look at THC a little bit closer. So in this slide, again, I make meconium and umbilical cord on the same slide to compare with each other. The number with in the circle means which test panel is included. So at least 5-panel through 13-panel, we have THC being tested. At the bottom, we see the positivity rate between the two specimen types we tested for, and there are the concentration distribution charts. So what it shows is that there is a middle line in here in the distribution chart. That means a median concentration. In other words, half of the population is below this concentration and the other half is above. And the upper and the lower limit of the color box, the upper one is a median of the upper half of the population, and the lower limit of the box is the median concentration of the lower. So in other words, it's a first to third quartile concentration range for each specimen type. So with this in mind, we can clearly see that the umbilical cord THCA or carboxy-THC concentration is much lower than that in meconium. So let's have a moment to get the concept of cutoff. So there are several ways of setting the cutoff. One cutoff can be made by the law. It may be made by the standardized guidelines. In some cases, they are made by the test methods capability. And in our lab, we set up the cutoff at the concentration above which our test methods are capable of resulting very accurate and precise quantitative results. So that doesn't mean the negative results mean that drugs is not present in the specimens. It's just simply that the concentration does not reach to the cutoff. So for example, if the cutoff would have been at 1 nanogram per gram in umbilical cord for carboxy THC, there would be more than half of the babies below that concentration. Although our cutoff is much lower than that, so we were able to gather this data to show you. Next, most prevalent drugs are a group of sedatives. And this aligns very well with what we observe nowadays. The incidence of maternal opiate use has increased. We see more and more incidents of neonatal abstinence syndrome, NAS. So what NAS is that they are a group of symptoms from the baby that may be born from the drug exposure environment, which means they're exposed to drug in utero. So when they're born, it's mostly associated with premature birth, lower birth weights, and there's a wide variety of symptoms: high-pitched cry, tremors, GI problems, feeding intolerance, and such. And all those observations are scored to see if it is fits the NAS diagnosis. The time of onset is drug type dependence, as listed over here, and the treatment approach really depends on how the babies are responding to each of them. It's quite a bit of financial burden for hospitals at a scale of $1 billion. From 2009 to 2012, it had doubled. So here's a map of showing the incidence of the NAS cases. Highest incidence happen in a southeast central area, followed by New England, then the other lighter gray areas. So what do we see in our labs? For both test methods, we test for hydrocodone, hydromorphone, codeine, and morphine. The positivity rate is slightly higher in umbilical cord than that in meconium, and those come from mostly the hydrocodone / hydromorphone positive cases. The codeine / morphine positive cases are quite similar between the two methods. And here are the concentrations in those two different types of specimens. Once again, their concentrations are much lower in the umbilical cord than that in meconium. On top of that, in the umbilical cord test method, we added 6-mem and mecanin as a marker indicative of heroin exposure. With only the morphine and codeine positive results, we cannot really differentiate between different types of the exposure. And here is how. For morphine, it's possible, but not very likely it will give us a 6-monoacetyl morphine metabolite. But it is much more likely that it comes from the metabolism of heroin. So 6-mem would be a better marker to say if the baby had been exposed to heroin. The shortcoming is that this metabolism just happens so fast that it may be deposited on the umbilical cord at very low concentration. So the absence of that analyte does not justify the abstinence of heroin use of the mother. So we looked at this Marley et al. Study suggesting that mecanin would be an alternative marker to 6-mem. It is a metabolite of the contaminants of heroin. So we introduced that to our opiates confirmation methods in umbilical cord in late 2012. And we did a 1-year survey published in this 2015 paper, we found that in morphine-positive cases, there are 1,700 cases, 5% of them were positive for 6-mem and or mechanin. On top of that, we were able to identify more cases without 6-mem but presence of mechanin. We did this similar survey in this 6-month period that's more recent. We noticed that the proportion of morphine-positive cases come from heroin exposure. And as you can see, they have increased quite a bit. So what are the concentrations looking? For 6-mem and mechanin, both of them are below 5 nanogram per gram. So coming back to the cutoff concept, if there is a cutoff set at 5, because of the test, how the test method is set up, we virtually cannot distinguish the babies exposed to morphine versus to heroin. Next most prevalent opioid is buprenorphine. We test both the parent drug and the metabolite norbuprenorphine. And once again, the umbilical cord could get a bit more positive cases, and those come from the cases with norbuprenorphine only. This is the concentration distribution again. You can see norbuprenorphine has much higher concentration compared to the parent drug. So if the test method setup has the metabolites, it can help identify the buprenorphine positive cases if we cannot find buprenorphine. Oxycodone is in part of 12 panels, or 9 plus oxycodone if that's the panel you choose to order. We identified more oxycodone positive case in umbilical cord compared to meconium. The only difference besides of the lower limit of quantitation is lower for umbilical cord is that we also look for oxymorphone, but that does not seem to give us more positive percentage. It's solely come from oxycodone. So once again, cutoff may make a difference. In methadone, we see a pretty comparable positivity rates between the two specimen types. They mostly come as both parent drug, the methadone, and the metabolite EDDP together in the case. So let's stop here for a while because those are the most popular opioids drugs that may cause NA symptoms. We identified 13% of meconium samples and 20% of umbilical cord samples overall. That is positive for at least one of the 4 drug types. What's interesting to us is that of those opioid positive cases, they are also positive for AMP, coke, or THC by 20%. And those are the type of the illicit drug that works differently as opioids, and they may complicate managing the NIH cases. I will close the analytical part by benzodiazepines. You might have noticed that the positivity rate in meconium is much less than that in umbilical cord. The reason for that is that there are much more analytes we included in umbilical cord. But if we're looking at just oxazepam, the positivity rate is very comparable. So I hope I have made my points of the importance of following the forensic principles to perform and approach neonatal drug testing. When we work up the case history, we do need to consider several factors that are pre-analytical and analytical for interpret the results. And I have demonstrated that umbilical cord tissues do collect drugs and metabolites at much lower concentrations than in meconium. So when we set up the methods or when we're choosing the appropriate method, those are something to keep in mind. And last but not least, meconium and umbilical cord provide similar positivity rates and prevalence of each drug type, and those are the prevalence that we see. So thank you very much for your attention, and I'll be happy to take any questions you have.
Thank you, Dr. Shu. We have some questions from the attendees, and I'm going to proceed with letting you know the first question that arrived from the panelists. The first question was, how has the recent legalization of marijuana in many states affected drug testing and the actions of healthcare workers once positive results are reached?
For answering how the legalization impacted drug testing, for our laboratory, we still test for them. The cutoff doesn't change. What do change in our observation is that the concentrations are higher. We did some Colorado-specific population comparing the concentration in meconium that was in 2012 versus in 2014. The positivity rate only slightly increased from 10 to 11%, if I remember correctly, but the concentrations are much higher. But that is only in meconium that we were seeing, because we did not collect that many umbilical cord cases from that state, but that's what we observe. As for the actions, once again, this is in a way, it's a collaboration between our laboratories if the clients call us for the results interpretation. Otherwise, I don't see the legalization can make things different from our end.
Thank you, Dr. Shu. The second question is testing recommended when the baby's mother has a marijuana card so she can legally use the drug?
It's a touchy question to answer, actually. There are various guidelines that have read. Each hospital has its own guideline when to trigger neonatal drug testing. That's one point I want to make up front. As of the guidelines, we don't really have a clear guideline that we can recommend to the hospitals. From what I understand is that there are several signs they observe from the mothers. They may not show up for their prenatal visits. They may have some other drug use history, even though they do have a prescription using marijuana at the time. But if there are some other risk factors that the doctors have observed, maybe marijuana is what they're looking for, but they might look for something else. So I hope I have answered this question.
Thank you, Dr. Shu. Another question that we had was, are there any specific sample collection techniques that need to be followed for urine, meconium, and umbilical cord tissue samples?
We do, at least for the samples that we receive, we have the collection instructions. And this will be the contact between the clients and the client services. And we'd be happy to provide the collection instruction for those specimen types. And Michelle, our marketing manager, is in the same room as me. Am I correct? There are instructions being posted on the website.
That is correct. They can find all of the instructions on
Yes,
our website.
there are all the instructions made available on USDTL website. For urine, I don't think we don't strongly recommend collecting urine for baby testing, to be honest. Um, so we don't really develop the instruction for collecting it. There is a clear instruction how to keep it forensically correct when the sample is sent and how we receive the samples.
I'll add an addition as well. Hopefully everybody can hear me, but because we are forensic, we follow the strict chain of custody, and that's a big difference in our collection instructions with our collection supplies, is that it is a forensic collection. So that's why we have our specific collection instructions.
Okay. For those who cannot hear what Michelle just said, she mentioned that we do have a specific collections for any type of newborn specimens. And I'm going back to the slides where the chain of custody form looks like. Here it is. If you can see it well enough, there is a checkbox for umbilical cord, meconium, blood spot, hair, and urine. So at least for the form, as a concern, there is some specimen type available if you choose to send the specimens for us to test. And we always just treat it like the forensic toxicology principles. The catch is we do have quite we may or we may not have the much lower cutoff than the adult urine type, and that is something that we need to work out between the clients and the client services. It would be very client specific when we have such a cutoff difference request.
Thank you, Dr. Shu. Another question that came in is, can you elaborate on the instrumental screening techniques?
Instrumental screen technique, there is a perfect example of what we do here. Ethyl glucuronide is ethanol metabolite. We also test for umbilical cord tissue. Currently, we can't have the immunoassays that is appropriate for this specimen type. So what we do is that principally it's the same technique. We have the LC-MS-MS method set up. What it screens for the first time, we only look at the quantitation ion transition, if you know the terminology. And when we confirm it, we go through the same analytical process. It's just that there is an extra ion transition that will add the extra layer of confirmation to the same technique. So in our mind, this can be considered as a compromised, different scientific principle, in a sense, in order to cover us to follow the principle. So I hope that would be a good example I give. I think out there they also have some instrumental screening technique that can screen all the drugs in just one run. In our lab, we don't do this.
Thank you. Another question that came in was, based on your THC study, they would like to know if you separated out the legal states for THC, such as Colorado and Washington.
Could you repeat the question once again?
Based on your THC study, they would like to know if you separated out the states that have THC legalized, such as Colorado and Washington.
No, we treat them the same way. In other words, the same cutoff.
Thank you. Another question that came in is, how should hospitals decide which test to routinely request? The 5, 7, up to the 13th drug panel. What are your thoughts?
My thought, let's go to, I'm sorry, I should have gone backwards. So this is the prevalence of the drug types, where which panel each drug type is belong to are color coded. I really think that it depends on what physicians expect to see, and see if the extended drugs is valuable for you to add on. That's number one. Number two, if the 5 panel is all you're looking for when you're suspicion about the mom's drug use behavior or history, 5 panel may be good enough. But I can't really represent all the community to recommend, which drug panel to order. What we do see is that if the 5 panel is ordered, about 10% of the samples will be missed positive for those extended drugs. We did some internal study. So 10% is, for some people, not so much. For some people, it may be quite a lot.
Thank you, Dr. Shu. Another question that arrived is, are consents needed in all states to obtain specimens?
Good question. Are there a consensus approaching the sample collection? Is that the question? Or is it a consent form? The consent form. That I do not really know. I don't think there is a consent form. Unless different hospitals have their own policy to approach cases.
I'm not aware of any state that requires
At least I have, I am not aware of the consent form that is mandatory by state authority.
Thank you, Dr. Shu. Another question that arrived is, what is USDTL's turnaround time for meconium and umbilical cord tissue drug samples?
Turnaround time, if the samples are negative results, meaning not reaching our cutoff, it will be released within a day, 1 day. And that is for general drug classes like I show on this slide. If the samples are requested for the alcohol biomarkers, those are ethylglucuronides, fatty acid ethyl esters, they may take 1 extra day to release out the positive samples. And if the positive samples, if there are positive results from the drug, it will be extra 2 days. So that would be the turnaround time. At least that turnaround time is from the time of we receive the samples. I need to make that clear.
Thank you, Dr. Shu. There was a question earlier from one of the attendees in regards to THC and obtaining authorization. I have actually a nurse that made a comment that I would like to point out to everyone right now. She has stated that she's a nurse at one of the largest delivering hospitals in Colorado. She doesn't treat the situation with a medical card for THC any different than without. THC isn't legal for newborns in Colorado, only those adults over 21. If a newborn tests positive for any drugs including THC, their social services are notified and they investigate the family. She also mentioned that Colorado doesn't have to get consent from a parent to test the baby.
Those are very good comments. I thank you very much.
Okay, so we still have some time for additional questions to come through. I'm going to wait about a few more minutes. Feel free to send any questions your way so that Dr. Shu can answer them. Thank you. Dr. Shu, a question came in stating, do you have any data on ethanol testing in meconium and umbilical cord samples?
The data, I did not analyze the data myself. What I do see is that in meconium, we test for different analytes. By its difference, it's different metabolites we're looking for the two specimen types. So first of all, there are two different analytes in two different specimen types. So there are two folds of differences. The difference is that in meconium, we test for fatty acid ethyl esters, and there have been some literature showing that fatty acid ethyl esters do not necessarily form because mother had been drinking during pregnancy. And that may explain some higher positivity rate we see from ethyl glucuronide, which is the kind we test in umbilical cord. And we always tell the clients by saying that when you receive the samples and the test results, always confirmed by site visit. Visit the family, visit their relatives, and ask some good questions to see if there are some clues about this. So short.
Thank you, Dr. Shu.
I'm sorry, Kia, but short answer is that we do see a higher positivity rate in fatty acid ethyl esters than that in ETG in umbilical cord. Thank you, Kia.
Thank you. Another question that came about was they wanted a little more clarification on our turnaround time. So I'll be more than happy to answer that for the attendee. It's 24 hours for screen negatives. If it screens positive, it will automatically go in for confirmation, and that could take an additional 24 to 48 hours. Dr. Shu, would you like to add on anything to what I just said?
What you just said is perfect. Thank you, Kia.
Thank you, Dr. Shu. Well, it seems like no more questions are coming our way. So I would like to thank you, Dr. Shu, for your time today, and USDTL would like to thank everyone who attended today's webinar and those of you who submitted your questions. A recording of today's webinar will be available on our website at www.usdtl.com. If you have any questions on today's topics, please submit them to our perinatal testing team at perinataltesting@usdtl.com. Thanks again, and we look forward to the next event. Have a great afternoon.
Thank you.